It's a pleasure to be with you. The title of this session is Injury and Non-Infectious Disease Control, Part 1, Unintentional Injury. There are no disclosures for this presentation. Objectives include review the leading causes of death in the United States, discuss why it's necessary for public health to address injuries and non-infectious diseases, review injury death statistics and demographic variations, review public health practices used to address injuries and non-infectious diseases, review major CDC action plans and strategies to address injuries and non-infectious diseases, review the four main CDC centers that address injuries and non-infectious diseases, review statistics and prevention programs to address vehicular injuries and deaths in children. Infectious disease control provided many early successes for public health and remains a major component of public health practice today. However, the scope and practice of public health in the United States has broadened since the 19th century to address additional health issues that impact morbidity and mortality. By 2019, non-infectious diseases, including injuries, accounted for 72% of total deaths in the United States. The predominance of non-infectious diseases and injuries as a leading cause of death has been evident for several decades. This slide shows the 10 leading causes of death in the United States from 1980 and 2019. During those 39 years, the only infectious disease on the list is influenza pneumonia, which dropped from being ranked 6th in 1980 to 9th in 2019. Heart disease, cancer, unintentional injuries, chronic lower respiratory disease, and cerebrovascular disease have consistently remained in the top 5 slots. Alzheimer's disease and kidney disease were not listed in 1980, but were ranked in the 6th and 8th positions respectively in 2019. Diabetes and suicide remain in the same ranked positions over these 39 years. Yet it's important to note that the percent of deaths due to diabetes rose from 1.7% in 1980 to 3.1% in 2019. A major point is that injuries and non-infectious diseases are the leading causes of death in the United States and must be addressed by public health. In 2020, COVID-19 became the third leading cause of death in the United States behind heart disease and cancer, demonstrating how an infectious disease, especially during a pandemic, can rapidly become a leading health concern. There are significant variations in cause of death by gender, age, and race and ethnicity that inform strategies to control injuries and non-infectious diseases. For example, let's consider injury deaths for 2019. For gender, males had a higher mortality from unintentional injuries and suicide than women. Unintentional injuries were the leading cause of death for those between 1 and 44 years old, accounting for 38.1% of deaths for those between 10 and 24 years old, 34.2% for those 25 to 44 years old, and 31% for children ages 1 to 9 years old, decreasing to 2.9 to 9% for those 45 years and older. There are also substantial differences in mortality by race and ethnicity. This table demonstrates the percent of injury deaths by race and ethnicity in the United States in 2019. American Indian, Alaska Natives had the highest percent of total injury deaths, 15.9%, followed by Hispanics, 12.4%, and Blacks, 10.0%. Asians had the lowest percent, 6.7%. American Indian, Alaska Natives had the highest percents for unintentional injury, 11.3%, and suicide, 3.0%. Assault death percent was highest for Blacks, 2.9%. Understanding differences like these we've mentioned is extremely important for public health when developing prevention and control strategies. Public health practices to address injuries and non-infectious diseases can be classified as surveillance and research and interventions to prevent and control. Surveillance and research includes providing information on incidence, prevalence, and risk factors, conducting research on causes and consequences, evaluating effectiveness of prevention and controlling interventions, and developing surveillance and research data systems. Interventions to prevent and control health problems includes providing risk reduction education for populations at risk, providing services like screening, treatment, and support, improving the social and physical environment to prevent health problems, which includes advocacy work and policy development. The list of injury prevention and non-infectious disease issues addressed by federal, state, and local public health in the United States is long and is only partially included on this slide, demonstrating the scope of public health practice. This table covers a partial list of CDC's national health initiatives, strategies, and action plans for injury and non-infectious disease control, and includes plans for Alzheimer's disease, chronic diseases including cancer and osteoporosis, environmental health issues including lead and other safety risks for children, heart disease and stroke, injury and violence prevention, which includes substance abuse, child injury prevention, suicide prevention, youth preparedness education, highway safety, and smoking and tobacco, including plans to control e-cigarette use. These action plans reflect the national public health agenda and inform state and local public health planning, federal funding proposals, and help prioritize public health activities. Major CDC centers and divisions that address injury and non-infectious disease prevention include the National Center on Birth Defects and Developmental Disabilities, the National Center for Chronic Disease Prevention and Health Promotion and its Division of Nutrition, Physical Activity, and Obesity, the National Center for Environmental Health and Agency for Toxic Substances and Disease Registry, and the National Center for Injury Prevention and Control and its Division of Unintended Injury Prevention. These centers report to the Deputy Director for Non-Infectious Diseases, forming one of the 5 major divisions of the CDC. Discussion of all of the CDC's injury and non-infectious disease prevention programs is beyond the scope of this talk. To illustrate CDC's public health practice efforts for injury and non-infectious disease control, I will use the remainder of this and the next session to examine 2 topics: motor vehicle injuries among children and teens, and childhood obesity. The CDC often guides state and local public health programs through cooperative agreements, provision of technical assistance, and categorical and block grants. Most public health surveillance, research, and policy implementation takes place at the state and local levels. The National Center for Injury Prevention and Control is CDC's major center for injury prevention. The center provides reports covering motor vehicle accident statistics and costs, both monetary and non-monetary. Motor vehicle accidents are a major cause of unintentional injuries in the United States. Motor vehicle crashes leave 25% of those 18 to 64 years old with a disability, increasing to 61% for those 65 years old and older. Motor vehicle accidents are a leading cause of years of life lost before age 75. Approximately 41,000 people died in motor vehicle crashes in 2020. Motor vehicle crashes resulted in 2.1 million emergency department visits in 2020 and cost the country over $430 billion, including medical costs and the cost of lives lost. In 2019, almost 2,400 teens, 13 to 19 years old, were killed in motor vehicle crashes in the United States, and about 258,000 were treated in emergency departments. In 2020, more than 607 children ages 12 years and younger died as occupants in motor vehicle crashes, and more than 63,000 were injured. In 2020, motor vehicle crashes were the leading cause of unintentional injury deaths for children and young adults 5 to 24 years old, and the second leading cause of unintentional injury deaths for children 1 to 4 years old. This sobering data underlines the importance of preventing motor vehicle injuries and fatalities, particularly for young people. Both reports from 1985 and 1989 of the Institute of Medicine and National Academy of Sciences called for a consolidated federal focus on injury prevention, recommending the following goals: build an injury prevention infrastructure, bring the public health perspective to injury prevention and apply the prevention techniques used to control infectious and chronic diseases to reducing injuries and their consequences. These reports resulted in CDC funding injury prevention programs nationwide through the National Center for Injury Prevention and Control. The core State Injury Prevention Program, SIP, is one of those CDC programs that facilitates surveillance and prevention to address motor vehicle crashes, traumatic brain injury, adverse childhood experiences, and local injury priorities. The three core SIP evidence-based goals are: 1. Engage in surveillance activities. 2. Strengthen strategic collaborations and partnerships. And 3. Conduct assessments and evaluations. As of 2022, Core SIP supports 23 funded state partners listed on this slide. 5 of the 23 funded states serve as regional network leaders that provide assistance, a regional structure for cross-state collaborations, develop partnerships with organizations and research centers, and help shape state, regional, and national injury prevention infrastructures and programs. 6 of the 23 funded state partners participate in Surveillance Quality Improvement, SQI, where they conduct injury data investigations to inform the development of uniform injury case definitions to improve injury data quality. Core SIP public health interventions are implemented at the state and local levels to ensure culturally appropriate programs responsive to local needs. Two prevention and control initiatives aimed at reducing motor vehicle injuries among children and teens are the Child Passenger Safety and Teen Drivers programs. Both the Child Passenger Safety and Teen Drivers initiatives emphasize primary prevention, particularly Education. The Child Passenger Safety Program was initiated in the 1970s, and due to programs like this, child passenger deaths declined 56% from 1975 to 2020, mainly attributed to the implementation of risk reduction measures that stem from safety research recommendations. A major risk factor for motor vehicle injuries and fatalities among children is alcohol impaired drivers. It's estimated that there are 2.5 million adult alcohol impaired drivers that have children living in their households. 24% of motor vehicle related deaths among children ages 0 to 14 years involve a drinking driver. 56% of children killed in motor vehicle crashes while riding with an alcohol impaired driver were not restrained, compared to 38% where the driver was not alcohol impaired. Another risk factor is no or inadequate use of restraints, for example, seat belts or booster seats. The rate of serious and fatal injuries to children can be reduced by 50% using age and size appropriate car and booster seats. Restraint use among young children often depends on the driver's seatbelt use. Almost 40% of children riding with an unbelted driver were unrestrained. Child restraint systems are often used incorrectly. One study found that 72% of nearly 3,500 observed car restraints and booster seats were misused in a way that could increase the child's risk of injury during a crash. Placing a child in the front seat of a motor vehicle is another risk factor. Riding in the back seat reduces the risk of serious injury by 16 to 40%. Principal interventions supported by child passenger safety research include educating people regarding the appropriate use of booster seats and seat belts, providing car seats to families with children, and advocating for child safety seat laws and their enforcement. There is strong evidence that these interventions increase child safety seat use. The task force on community preventive services found that education alone was not effective, but did find that incentives that rewarded parents for obtaining and correctly using child safety seats or directly rewarding children for correctly using safety seats together with education programs were effective. All states currently have child safety seat laws in place. Child safety seat laws increase child safety seat use by 13%, reduce car crash fatal injuries by 35%, and reduce all injuries by 17%. Child passenger deaths have declined steadily since they were identified in the 1970s as a public health problem that could be prevented. The Child Passenger Safety website is listed on this slide. This website is a great source for child motor vehicle safety educational materials. The Teen Drivers Program was also initiated in the 1970s. In 2020, 2,800 teens, 13 to 19 years old, were killed and approximately 227,000 injured in motor vehicle crashes. These crash-related injuries resulted in about $40.7 billion in medical costs. Due to programs like Teen Drivers, teenage crash deaths have declined 71% for males and 61% for females since 1975. The risk factors for motor vehicle fatalities and injuries by teen drivers have been identified through surveillance and research of the National Center for Injury Prevention and Control's Teen Driver Program. Teen driver risk factors are listed on this slide. Being 16 to 19 years old. Per mile driven, teen drivers aged 16 to 19 are 3 times more likely than older drivers to be involved in a crash. Male gender. In 2020, crash death rates for male drivers 16 to 19 years old was 3 times higher than the death rate for 16 to 19-year-old females. Teen drivers with teen passengers. This risk increases with the number of teen passengers and the presence of male teenage passengers. Newly licensed teen drivers. The crash risk is particularly high during the first year of licensure. Inexperience. Teens are more likely to not recognize or underestimate dangerous situations and make critical errors. Nighttime and weekend driving. In 2020, per miles driven, the fatal crash rate at night for teen drivers 16 to 19 years old was about 3 times higher than that of adult drivers 30 to 59 years old. 44% of crash deaths among 13 to 19-year-olds occurred between 9 p.m. and 6 a.m., and 50% occurred on Friday through Sunday. Not using seat belts. In 2020, 56% of 16 to 19-year-olds killed in a crash were not using a seatbelt. Distracted driving. In 2019, among U.S. high school students who drove, 39% texted or emailed while driving at least once during the prior 30 days. Speeding. Approximately 35% of male drivers and 18% of female drivers 15 to 20 years old who were involved in fatal crashes were speeding. Alcohol or drugs. In 2021, 27% of young drivers 15 to 20 years old who were killed in crashes had blood alcohol levels of 0.1 grams per deciliter or higher. Prevention interventions for the Teen Drivers Program is similar to those of the Child Passenger Safety Initiative. Education, use of restraints, and advocacy for teen safe driving laws and enforcement. Teen driving education strategies include school and peer organization-based instructional programs and social norming campaigns. School and peer-based instructional programs commonly focus on drinking and driving (DD) and riding with a drinking driver (RDD), with some programs targeting the consequences of substance use and others more directly focused on alcohol-impaired driving. School-based peer organizations are groups of students, often with faculty advisors, who encourage other students to refrain from drinking and driving, and riding with a drinking driver. An example is Students Against Destructive Decisions, SAD, that uses peer-to-peer messaging strategies along with external expert information. Other examples include the Parents Are the Key programs that provide parents with materials on how to help their teens avoid motor vehicle crashes through the process of learning to drive. This program includes developing a parent-teen driving agreement. Social norming programs generally consist of ongoing multi-year public information campaigns conducted on college campuses to reduce alcohol use by providing students with consistent and repetitive objective information to change normative habits and behaviors. Advocacy interventions include encouraging the building of safer motor vehicles, development, implementation, and enforcement of laws, and changing community attitudes about teen driving. Effective laws to decrease teen vehicle injuries and deaths include lowering blood alcohol concentration laws for young drivers, instituting sobriety checkpoints, raising the minimum legal drinking age to 21 years old, and utilizing a graduated driver licensing GDL system. GDL gradually increases a young driver from a restricted to a full license while the teen is gaining driving experience. GDL is associated with a 21% reduction of crash fatalities and a 19% reduction of injuries in 16-year-old drivers. GDL systems exist in all U.S. states and the District of Columbia, but the strength of GDL laws varies by state. The most effective GDL laws use a three-stage licensing process. Stage 1, learner's permit issued, a minimum age of 16 years old, a 12-month minimum duration of the permit, and having completed at least 70 supervised practice hours. Stage 2, intermediate provisional license, which includes no teen or young adult passengers and restrictions on nighttime driving from 9 or 10 p.m. until 5 a.m. or longer. Stage 3, full licensure with a minimum age of 18 years old. Public health injury prevention interventions work. There was a marked decline in motor vehicle deaths for both males and females 15 to 24 years old from 2000 to 2018. The National Center for Injury Prevention and Control accelerated its vehicular crash prevention effort for young people between 2000 to 2005. In 1999, motor vehicle death rates among males were highest for those 15 to 24 years old at 35 per 100,000. By 2019, the rate for males in that age group was 19, which was lower than that for males aged 25 to 64 at 19.7, and for males aged 65 and over at 21.8. Vehicular crash death rates for males 0 to 14 years old decreased 56% from 4.5 per 100,000 in 1999 to 2.0 in 2019. In summary, the practice of public health in the United States has broadened since the 19th century to include injuries and non-infectious diseases. Injuries and non-infectious diseases are the leading causes of death in the United States. There are significant variations in cause of death by gender, age, and race and ethnicity that inform strategies to control injuries and non-infectious diseases. The CDC often guides states and local public health programs through cooperative agreements and provision of technical assistance and categorical and block grants. Education plus incentives are effective in increasing the use of child restraints in vehicles. Graduated driver's licensing GDL is associated with a 21% reduction of crash fatalities. Public health injury prevention interventions work.